something went out with the internet. So it is my distinct pleasure to introduce Dr. Italo Brown. And, sometimes people don't want lengthy bios read, but I think it's of the utmost importance that you hear everything that Dr. Brown has been doing. And even in this brief intro, it is not everything that he does. So Dr. Italo Brown is an assistant professor in emergency medicine and health equity and social justice curriculum thread lead at Stanford University School of Medicine. Throughout his career, Italo has been at the front lines of social medicine and health equity. He is the current Chief Impact Officer of Trap Medicine, a barbershop-based wellness initiative that leverages the cultural capital of barbershops to address the physical and emotional health of Black men and boys. He is a former board member of the Tennessee Healthcare Campaign, an organization that spearheads statewide advocacy efforts in support of the Affordable Care Act and Medicare and Medicaid reform. Italo trained at Jacobi Medical Center and Montefiore Medical Center, two Bronx hospitals ranked among the top 20 busiest ERs in the country. In 2017, the National Minority Quality Forum named Dr. Brown amongst the 40 under 40 leaders in minority health. As an avid writer, he also served with the ABC News Medical Unit and has contributed to health equity and wellness commentary to the New York Times, NPR, USA Today, GQ, Men's Fitness, and Bloomberg. Italo serves as a diversity, equity, and inclusion consultant for organizations like Google and YouTube, and recently was selected to be among clinician leaders in access to care for the Recurring Health Equity Leaders Roundtable, a new initiative by the Office of Public Engagement in the White House, and something that I've had the opportunity to serve and partner next to him in doing so. So without further ado, I want to then turn over the microphone to my colleague, my friend, my fellow Black man in medicine, Dr. Italo Brown.
Dr. O, you really know how to bring someone out. I'll tell you that much. You knew exactly what you were doing. And I am thankful. I'm just so blessed to be here today. I'm going to set my presentation up and I'm going to need some confirmation from you all. All right. Do you all see my notes or my slides?
We now see your slides.
Great. Slides. Excellent. So, like I said, Dr. O, you're a true champion for equity and an absolute inspiration to not just myself, but many of us. And I thank you for that introduction. I also want to give a huge shout out to Daniela and everyone who has been corresponding with me before today and this morning. Thanks so much for your help. I bring you all greetings from Stanford. I'm a part of the Department of Emergency Medicine, but I also sit on the Social Justice and Health Equity Curriculum team. I'm so proud of the work that our team has been able to do in the last year that I've been a part of this thread. And then finally, my mentors, Alden Landry, L.A. Alvarez, brothers, UT Bay SEN, my sister, Uche Blackstock, and Tyson Bell and Quinn Capers are all individuals who have greatly influenced the way that I approach health equity in this lecture. So today we're going to talk about a bunch of different things, but the name of the title is Against the Grain, Centering Diversity in the Fight for Health Equity. Here are a set of my disclosures, none of which are currently active. I typically start my conversations by delivering either a trigger warning or some setting of admission of biases. So here, I'd like to do that. Some of what we'll discuss today will conjure maybe some prior trauma, maybe an exposure to trauma that you've had personally, and I want to acknowledge that. I also want to establish a zone of safety here. This is a judgment-free space. The things that we'll discuss have certain tones, and I want everyone to feel like they are okay to not know or to have bias. In fact, I'll admit my own biases. I operate as a cisgender male with a heteronormative bias. I tend to focus on anti-Black sentiment in my presentations. But my hope is that the skills that I present, the root of what I discuss, can be applied to all frames of identity. Okay? Let's talk today, like actual bare conversation. The objectives that I typically lean towards: describing a problem, examining its drivers, and identifying strategies. Every presentation I give is these three things, but let's clarify what that means a little bit. So today we're going to define some of the language of health equity. So making sure that you know the difference between social drivers of health, health disparities, health equity, diversity, even race and racism to some degree, right? We'll also examine the drivers, like how the current climate of diversity is viewed in our healthcare ecosystem. And then we'll examine some of the business cases, or rather the rationale for diversity and how it'll impact health equity. And finally, we round out with identifying strategies that share the discrete actions of our efforts at this moment, and give you all a framework for our learners to champion diversity in everything that they do and fight for health equity. So without further ado, let's dive in to figure out how we can go against the grain even further and make it a viral concept. I've got a couple pictures here. On the left is a gentleman named Bill Jenkins. Bill Jenkins is by many held to be the individual who exposed the Tuskegee syphilis study to the federal government. He died a few years ago, and I had the pleasure of sitting in Bill Jenkins' class as a Morehouse student. Bill Jenkins walked in the room on my first day of class and was like, "You think you know health, but you have no idea," essentially. And then started to talk about John Snow and the elements of public health. He led our epidemiology course with a certain level of ferocity, and it brought me alive, because for the first time, I was not just thinking about being a doctor. I wanted to initially be a sports medicine physician because I wanted to sit courtside at basketball games. But for the first time, he sparked my mind to think about the inequity in healthcare. And this is many, many years ago. Fast forward to when I was in medical school, found myself advocating for the Tennessee healthcare campaign as a Medicare reform communicator. So I would go into communities and speak to them about the importance of voting for these different measures and what Medicare and Medicaid reform meant. I understood that health equity was multifactorial then, but had the benefit of being groomed in an environment that nurtured my interests, that nurtured my inquiry and my curiosity around improving health outcomes. And then the picture on the right is sometimes heart-wrenching, because I watched my mother's health deteriorate throughout this entire continuum. It's the heart-wrenching irony essentially is that even with the son who was training a physician and at that time actually became a physician, her health options and decisions were greatly impacted by non-medical factors. And ultimately, her demise was a function of our broken healthcare system. But she's not alone here, right? And I honor her memory through the work that I do. We know that health outcomes differ along a variety of lines. We know that there are racial and ethnic differences among health outcomes. Black and brown communities are disproportionately represented among the leading causes of death in the US. And while social and structural drivers of health provide some support for these differences, it doesn't explain all the disparities entirely. And each one of you, as you go through your medical journey, will see these patients that I have here, patients who miss dialysis. Huge shout out to the lecturer earlier who spoke about her program. But you'll see patients who are incarcerated. You'll see the glazed look on a patient's face when you see that they're not getting the information because it's delivered in a language that is not native to them. You'll understand what it's like for someone who has to transport themselves at great distances just to get suboptimal care, or who have nowhere to return to at all. These are complicated cases, but the medical care that they receive shouldn't be complicated. And we have to familiarize ourselves with these images, with these narratives, because essentially this is what we fight for. These are the reasons why we believe in the tenets of practicing medicine, is to make sure that everyone has access to the greatest care possible. And we are simply a part of that equation. So if we're going to talk the talk, we need to understand the language with a surgical level of precision. So I have here for you all, this is one of those slides that if you're at home, you want to make sure you get this down right, screenshot it, okay? Absolutely fair game. Social and structural drivers of health, okay? You've heard a lot of this in the last, I'm assuming, 5 years. These are the non-medical drivers of health outcomes. Those are things like access, employment, insurance, education, income, transportation, and housing. Non-medical drivers that influence health outcomes. Health disparities. So when we talk about health disparities, understand that this is a comparison, right? You're looking at discrepancies between different groups in terms of health outcomes. And it's usually based upon some type of a identification category like race, ethnicity, gender, ability, geography, or socioeconomic status. Now, health equity is something different. Health equity is it's an expectation. It's an expectation that every person, regardless of the classification that they come from, can achieve optimal health or optimal health outcomes. And sometimes when you're looking through media or seeing this referred to in some didactic conversations, there seems to be this interchangeable use of equity and equality. And I posit that it is not interchangeable. They are two total separate things, right? And so let's make sure that we understand the difference. By definition, equality is all stakeholders getting the same resources regardless of the circumstances. And inequity, however, is when the circumstances inform resource allocation to ensure that all have access to these outcomes. Every single stakeholder should have this equal outcome access, all right? I use this analogy of a track and field track, right? If you ever gone to an event, you'll see the track, and there's certain ways the numbers are distributed on the track. If they are lined all the way across, that represents equality because all the runners are starting from the same position. But what is being failed to account for here, or what is not accounted for here, is the distance from the innermost lane and the outermost lane are different. That innermost lane runs a shorter lap than the outermost lane. And so to create and establish equity, stagger the numbers. Now you start to see the picture, right? You see that there is a circumstance taken into account and everyone has the outcome of winning or crossing that finish line equitably distributed. Diversity is defined by the AAMC as, or broadly defined, essentially to include all aspects of human differences, including, but not limited to, socioeconomic status, race, ethnicity, language, nationality, sex, gender identity, sexual orientation, religion and geography, disability, and age. In 2011, the AAMC starts to really generate this momentum around diversity and inclusion conversation. What we start to see is studies develop over the course of 10 years that demonstrate the lack of diversity, how exclusive the learning environments can feel and be, and what the lived experiences are of those who are matriculating through a medical education system. And then the link comes where we see health outcomes. Is it possible that the reason why our outcomes differ so greatly is because we're not valuing the fact that the patients we serve come from all walks of life? We don't see that reflected on the front end. So there's an illusion of equity. And nothing made this more painstakingly clear than this recent pandemic, where we watched in front of our eyes as a captive audience, health outcomes significantly differ based upon ethnic lines, based upon access, based upon all of these drivers that we've discussed previously in this presentation. And among those who are initiated, meaning those who understood this, it was just preaching to the choir. It was more of the same. But for many, this was their crash course in the reality of the American healthcare system. And so it forces us to really take a critical look at ourselves and say, what actions are we doing? How are we distributing our resources? What value do we place on the lives of one another? Or is it just about what we want at that time? So in the midst of this understanding where everybody now is focusing on health, we get to see other factors taken into account here. I want to come back to this slide for a second. It's a little out of sequence. We get this watershed moment, right? So in the midst of this pandemic, we're forced to look racism in the eyes. through the murders of unarmed Black men and women. It really sparks or reinvigorates a social justice movement here in the US. And so out of this space, more overlap about how we should address discrimination and bias, how we should address microaggressions, leading with things like empathy, compassion, and acknowledging that pain can be felt from any form of identity. This comes out of the last 2 years. I have here a statement released by the AAMC that is absolutely a profound change from, or a profound shift from the medicine of 20 years ago. We're now naming things, saying that we need to lead in educating ourselves and one another about these social issues. We need to move from rhetoric to action. And in case we were not clear about what this particular systemic issue is, or the systemic nature of something like racism that, again, helped to jumpstart or reinvigorate the movement around social justice, I have a little graphic here that I think gives us a picture of what that seems like. So movement from individual racism, individuals' creation of bias and discrimination, when that synergizes, there's collective racism. So groups acting in this same fashion. That gives rise to systematic and institutional racism, where you see that the structures and edifices and many of the policies that are existing have an impact disproportionately on certain groups of people. And then there's systemic and structural racism, racism that is chronic, that is calcified. And we see that evidenced by worse mortality and morbidity rates. And at any point, you can have the insertion of the, I guess, amplifying effect of social drivers and structural drivers of health. So what it comes down to is these three things over the last couple of years, kind of, boiled down information: anti-racism, diversity, equity, and inclusion, restorative justice. Anti-racism, meaning the acknowledgement of systemic and structural racism baked into medical education that impacts equitable healthcare delivery. Then our diversity, equity, and inclusion push, the knowledge that representation is what we seek. And under addressing it somehow contributes to worse health outcomes and leads to health inequity. And then restorative justice, which is taking responsibility of our collective missteps and broadly initiating things that would help heal and improve and build relationships of trust with communities that have been marginalized or considered vulnerable. None of these actions are popular and they cannot be performative. So this is where we're led to now, the fabric of our conversations. And it feels like this young child here, where you're looking at this staircase, you're like, oh my gosh, man, what do I do? I'm just a student. How do I get from point A to point Z? Where is my station in this? I know it feels overwhelming, but in these moments, I encourage you to think about this. It says you don't have to see the whole staircase just to take the first step. I mean, the reasons why I believe that you all are here today is because this represents you taking not just the first step, but a collective first step. Maybe this is many first steps, but the hope is that we're modeling the behavior that we want the system to take on. So we spent some time talking about the problem. I want to go a little bit deeper. Let's dive into some of these issues with diversity that are present and why there is a business case for having diversity in medicine to improve health outcomes. I know that the phrase implicit bias seems at this point a little bit like a token phrase, but when we really think about implicit and explicit biases, what makes it fresh to me is the fact that it is still happening and the fact that we still see patients and their outcomes significantly different because of the effect of these things. Now, implicit biases are activated by subliminal primes. That could be something that's environmental or situational, developed over the course of a lifetime, right? And our micro interactions, our involvement with different stimuli, the media, ecosystem that we work in and live in, these things help to shape those biases that we have. The harmful part is that it gives rise to this phenomenon known as othering, where we view or treat people intrinsically different from ourselves, like they are alien to what we know and what we are about. Unfortunately, there's a parallel here, right? So as these develop, we also see this happen along the same lines as health disparities, and we can trace this. It's important to acknowledge that this has a profound impact on the way that we practice medicine, on the ways that we teach others, and on the ways that we propagate healthcare and our compassion, so to speak, to patients. But there are other features of this that we see at the individual, the group, and the institution levels. At the individual level, what we know is that minoritized medical trainees report a higher degree of microaggressions, higher racial bias, or evidence of discrimination. And these facets contribute to higher burnout rates for minoritized communities, specifically in medical training. The constant threat of not being adequate, despite having the same exact, if not greater qualifications, is what we continue to call imposter syndrome. And we see this very commonly among minoritized populations and women. We also know that this has this resting discrimination, or the threat of discrimination can lead to physiological and psychological changes. Many of this has been documented in literature, from elevated blood pressure, cortisol levels, inflammatory markers, in higher degrees of PTSD, anxiety, and depression. This is the reality of any historically marginalized person matriculating through the medical education system. At the group level, we see a lack of diversity in medicine. This is no aha moment. We know this. And it's interesting because at every single level of training, you start to see this particular dynamic preserved. The graph on the left shows that it's a racial demographic breakdown of the US medical graduates from 2018 to 2019. And the takeaway here is that there are certain populations that do not have the concomitant representation as they do by US Census, right? Specifically, I highlight, as I said, Blacks here are 6%, but in the US population, they're about double that. And so how do you create a system where the interests of a population are taken seriously if they're underrepresented in the medical community? But what about the ranks of faculty and faculty and departmental leadership, right? 5.5% of medical school faculty identify as Latinx, 3.6% Black or African American, and 0.2% as Native American or Alaskan Native. Far underrepresented. At the institution level, we're dealing with something very sophisticated here, right? This graph shows us the frequency, or rather the likelihood, of reported professions stratified by ethnicity. And if you look at these numbers, as you go down to the considered lower skill level tasks or lower skill level occupations, the representation of ethnic minorities increases. But when it comes to those who are at the decision-making arm, there's underrepresentation. The next one to the right states essentially minority representation among hospital leadership. And I think that this is extremely profound, right? That diversity among hospital leadership teams has been lacking and worsening. Minorities make up about 30% of the patients that are seen by these institutions, but only hold 11% of executive positions at hospitals. This is significantly different from, well, not different, but this is a slope, a downward grade slope from what we recognized in the early 2010s. And I think that the hard part here is realizing that minority representation in every C-suite position has either decreased or remained flat since then. At the institution level, we also have to think about how this affects patients, right? Patients from historically marginalized backgrounds have a greater likelihood of receiving care from low quality, high cost medical institutions and medical centers. This is a phenomenon that's starting to be known as medical segregation, where we see that the faces that are that are at these underfunded institutions with limited specialty care are typically those of minoritized or historically marginalized communities. All of this should be ringing a bell. How do you solve it? There's a lack of representation on the front end. There's a lack of representation at every level, even at the institution level. But what about at the research level? We see that there's differential funding, that there are fewer R1 grants provided, or typically people who come from minoritized communities perform poorly in the grant funding process. And it can't be explained simply by saying that the talent is not there. That is false. Even when the topics are related to issues that historically have been covered by minoritized communities, such as diversity, equity, inclusion, or health equity concepts, there is still underfunding of minoritized populations. There are fewer people who come from minoritized or vulnerable backgrounds represented on editorial boards, even to the point where there have been faux pas made by editors as recently as a year and a half ago that minimize the effects of systemic and structural racism, discrimination, and even the impact of social and structural drivers on health equity. But how does this affect your practice? And I think that this is critical as a student going into the medical ecosystem. We know that in the 2000s and 2010s, there started to become a wealth of research around patient-provider relationships and their effect on health outcomes. This concordance conversation essentially has carried through and has led to some very fascinating findings. We know that healthcare studies demonstrate patients generally fare better when the care is provided by a more diverse team. The professional skills-focused studies also show that improvements in innovation can be driven by team diversity, improvements in quality driven by team diversity, improvements in risk assessment, financial performance, all driven by diversity. There's mounting evidence that demonstrates that physicians and patients, when they share some commonality, it improves the way that they interpret health, the way that they achieve their health outcomes. I have a couple studies here where we show that there was an improvement in time spent together, medication adherence, the shared decision-making capacity, wait times, screening for different illnesses. All of these things increased with diversity. The understanding of their own risk for cancer, their understanding of medical treatments and therapeutics, all increased when there was concordance. And more importantly, or rather not surprisingly, implicit bias is diminished when there's some concordance. These particular studies stand out to me for a couple of reasons. One, because it's provocative. When you see the headline that a lack of Black doctors is killing Black babies, these are meant to get the eyes of those who are not just in the medical sphere, but to show that there is true evidence that shows that when a Black newborn is cared for by a Black physician, the mortality penalty that they suffer is cut in half. Even the studies in Oakland, where there was a demonstrated concordance and adherence to cardiovascular medications, and ultimately mortality was decreased by 19% as they saw more diversity. There's a clear business case here among healthcare leadership, among all of the entities within healthcare, to prioritize diversity in order to get equitable outcomes. This framework provided by the AAMC, I think, it articulates this the best that I've ever seen. I'm not a fan of the color, the graphic itself. I think it could be better, but it articulates exactly what I think is important here. That there's a range of extrinsic and intrinsic benefits to having diversity, and it has a longitudinal relationship to improvement in care. First, you see in this left-hand column where it says diversity that you get automatic innovation and creativity. That is something that is often scarce in terms of medical education and advancing healthcare, right? We need more thinkers. We need more brainstorming. Well, it comes from having diversity of thought, and that is a function of who's in the room. You see the approach to problems and critical insight change, meaning like if you have more voices and more people in the space, the ways you would approach a specific problem and solve it also have more texture. These give rise to an inclusive culture and an environment. Obviously, it's not 100% the responsibility of those who are in the diverse population to create that. It is the role and responsibility of who is facilitating the environment. But notice that with more diversity, you start to see a feed-forward mechanism. And then ultimately, the goal of equity can be actualized when these things are prioritized. So if I haven't driven it home enough, diversity gives rise to increased health equity, which gives rise to increased positive health outcomes and reduction of health disparities. And so the question becomes, where along this pathway do we sit and how do we influence it? This is where I describe the strategies. We'll talk a little bit about these. So there was a report, again, that came out by the AAMC a few years ago, which I think outlines some measures that are pretty unique. What it boils down to is the current solutions and routes that people are taking for short-term success are increasing recruitment and retention. So significant effort and actual financial resources have been placed towards trying to create robust recruitment of marginalized communities, formerly known as URMs, or historically marginalized populations. The retention element has been a struggle since the beginning of having medical students in general. But the hope is by equipping them with a community and having culture shift within that space, it influences retention. The second thing I see is scholarship, mentorship, and sponsorship. So increased focus on funding individuals who typically are limited by circumstances to pursue medical education. Then watering them through mentorship, having adequate mentors who are willing to be champions for them and advocate for them. And then sponsorship, meaning when they're not in a room, they leverage their privilege and leverage their platforms and power to advance those who come from vulnerable communities and marginalized populations. And then finally, there's a sincere focus on community engagement and partnership. What that means is if you are constantly weaving in the communities from which these individuals come from into the fabric of that medical ecosystem, bringing them on as even partners and stakeholders, there's a greater likelihood to see those who come from the communities feel safe, feel a sense of purpose in the work that they're doing, and feel inextricably tied to what they believe brought them to medicine in the first place. But with that said, this red text here, I think is very stark. After acknowledging that, Dr. Acosta goes on to say, indeed, it is becoming clear that the next generation of work for diversity and inclusion in academic medicine must include a deeper focus on changing the culture and climate of our learning and workspace environments toward one that practices equity-mindedness and conscious inclusion. What this is talking about is you all. You're a part of this next phase. We have to embrace that. So how do we move this needle? What does it look like for us to have advanced this as learners? Because we understand what's being expected and required at the institution level. We understand what's being expected and required out of the DEI committees and task forces and all of the different figureheads who have now been labeled so that you have someone driving change and creating these metrics. But how does that translate into student effort? How does that create an environment where the student who wants to see change actually feels like they have a stake in this discussion? So the mnemonic that I'm using is ACED, A-C-E-D. So here's how we're going to close that gap. The first is the A, apply pressure. Just like you are seeing a hemorrhaging wound and they tell you the best thing that you can do for that is to apply pressure. What I mean by that is you have to push the administrators to be transparent. there's a need for reform in undergraduate and graduate medical education to have a laser focus on principles of equity, justice, and inclusion, you can push them. And you can do it in an insightful way. Making sure that you're honest about what your needs are, being critical about the space that is present, challenging your instructors to lead from a space of equity in terms of how they lead, how they educate, and asking for the results of all of these committees that are created. Here are a couple tough questions that you can ask that apply pressure. One, how is your institution supporting members of historically marginalized groups? Like via a report. Also, is there transparency about where the diversity, equity, and inclusion dollars are going? And can you all report, I would say quarterly, on the progress of these key performance indicators tied to the investment? That is something that as a student you can ask for. And it applies pressure to say that, hey, we're looking. We're not just going through the motions. We are trying to actively engage with the changes that you say that you're making. But it doesn't have to stop there. You all can lead your own efforts, and you can ask administration to focus on championing the efforts that you all build, whether it's through the community or whether it's through organizations that are native to your institution. The C, cultivate champions. And what I mean by this is essentially realizing that it is pathway development that leads to having an increased recruitment or a more presence of diversity in the ranks of medicine. What the problem is now is most recruitment efforts start in high school. We need to start earlier. And as a student, you have a greater likelihood of relating to those who are in elementary school and middle school. So be a DEI influencer. Not just, and I say that not in terms of social media, but it can work there too, but actively trying to influence and create a viral exposure to health equity concepts as early as elementary school and middle school. You should showcase the fact that you're building clinicians of tomorrow today. I also think that's important to advocate fiercely and organize. Build health equity leaders among your community, at your medical community, with a mindset that is steeped in intersectionality. Don't be afraid to collaborate, to cross-inspire, and to share that work. As I stated earlier, you gotta leave tracks, because if they are not there, no one will know how to do it. Extend into communities. That's the E from ACE. I'd like to see institutions gather around or rally around our students as they do community engaged work. But also recognize that as a student, you are far more nimble than any institution can ever be. You can organize, you can exact movement, you can actually make a difference from a position where you have more flexibility. We should activate our community advocates, go through the needs assessments, understand what they want, and be able to communicate that across the entire gradient, from your instructors to your administrators to those who are at the level of upper level leadership or management. All right. And then you bring the community to the table right there next to you. Here's an example of us. I want to highlight this before I close. Jamil Lacey, he's the gentleman in the middle who's got on the shirt and the Oakland Raiders hat, started this before he was a medical student. He's currently a medical student operating TRAP as a CEO and president of TRAP Medicine. This is a student-run initiative without ties to a major institution, because it started from the mind of somebody who was nimble and could make change and was dedicated to that. And then the last one is D, drive the narrative. What I mean by driving the narrative is, we understand that patient care is the focus, and I think that most institutions also ascribe to that. But are we centering their experience? Are we centering the fact that there is an increased diversity among the patients that we see and their needs? And to meet that, we must also diversify the medical education system and those entities within. We've got to change these things. But the narrative can be established and driven through students, because you all are stakeholders that most institutions listen to because it follows money. We can't continue to practice the medicine of 50 years ago. This model has to be changed to have equity-informed steps and acknowledging the fact that in this discussion, in this entire longitudinal course, you all are the vessels, is the key. So I've spent some time today talking about some of the factors that drive health equity, why diversity has a true business case. And I've shared with you some of the strategies that are used at this moment and what you as students can do to really increase diversity and drive health equity. It is difficult to go against the grain, but it is the most rewarding thing that I've ever done. And I encourage every last one of you to do exactly what your heart says, because patients need you. And the patients that need you look like everybody. All right. With that said, I am closing, and I would like to go ahead and open up for any questions that are in the chat group.
Thank you so much for that talk, Dr. Brown. And I'm going to kick us off with a question that I actually have. I think your energy for this is just amazing. It just lifts my heart to hear you talk about this. And I'm wondering if you have any advice on how we can sustain our energy doing this work when it seems like we're in a climate that doesn't want to see us progress, and when we can really feel like we're being pushed back. How do you sustain the energy still?
That's a great question. So there's a couple of things. One, acknowledging that there are constant, threats to that energy is important. We have to be realistic with ourselves and say you're going to encounter some entities that do not agree with what you're doing. That doesn't mean that it's not the right thing to do. The other part is rest is revolutionary to some degree, right? If you give yourself time to actually recuperate and rejuvenate, like that recovery is important. So after every single major push that you do, allowing for some recovery time helps to kind of drive away from the burnout of doing equity-driven work, right? I also think you should lean into the fact that there's community here, right? Like, it makes me warm when I see Dr. O, because I know that we're both doing work that is in this space, and it just, which part of the piston is pumping? That's all I think about. If he's up and I need it to be down, that's okay. If he's down and I need to be up, that's fine. But I can always lean on the fact that we're always working and pushing for this particular thing to be a reality. The other part I would add is not just that you're not alone, but there are others who are at other stations in their career who you can come to. Come to us. Let some of that go. Let some of it down. Those safe spaces are important. And I can think about this it's interesting that you say that, but there are so many times that I've had learners come to me and just say, Italo, like, I'm trying to do this, I'm not getting anywhere with it. And that frustration, you can see it on their face. And I take pride in being able to tell them it's going to work out because I'm evidence of it. I remember being essentially frustrated. And I went to a historically Black college twice and trying to get these things across and be like, administration is working against me, or feeling like, oh man, they don't want to support me. So I know that face. I know that feeling. We're here because we expect, as a part of the social contract for working in this space, that we help others who are trying to do it. So absolutely rest, lean into community, take a load off, make sure that you are, again, rejuvenating that desire.
Thank you so much. I really appreciate your input on this, and I'm sure I'm speaking for many of the medical students on the conference today that feel the same. Thank you again, Dr. Brown, so much for sharing your perspectives.
No problem.